who gave me the opportunity to present the topic in this big audience. So let me start the topic. So first, for understanding the ventilation, we need to know what is normal breathing. So we need to know the normal mechanics of breathing, and then we go into understanding what is the mechanical ventilation mechanics. So first, about normal mechanics of the spontaneous ventilation. Spontaneous ventilation or spontaneous breathing involves the contraction of the muscles of inspiration. So we have an inspiration followed by an expiration. So that constitutes the respiration. So the inspiration is active from body and the expiration is passive. So for inspiration, we have either a quiet inspiration or when there is some maximal inspiration. During a quiet inspiration, it involves the contraction of the primary muscle of the respiration, which is the diaphragm. The diaphragm contracts and it shortens and it flattens and moves the abdominal contents below, and it increases the vertical size of the thoracic cavity. So the size of the thoracic cavity, and there will be inside the cavity. That is what happens in a quiet respiration. So quiet inspiration, there are two muscles. So one will be the diaphragm and the external intercostal muscle that raises the ribs slightly. It increases the circumference of the thorax. And during a maximal inspiration, so it's a good movement of the diaphragm and the intercostal muscle and a small increase in the vertical circumference of the thorax. During max inspiration, that's so these the accessory muscles of the expiration are used to compress the thorax and the air moves out. So these are the muscles of accessory muscles of expiration that everyone might be knowing. That inspiration, we have usually see this inspiratory accessory muscles are in the upper part of the thorax, scalene, sternocleidomastoid, pectoralis, trapezius, latissimus dorsi, mainly around the thorax. The expiratory muscles are mainly in the abdomen, so that the rectus abdominis, external oblique, internal oblique, the transverse abdominis, and serratus. All these are usually in the abdomen. It compresses the abdomen and pushes the diaphragm upwards and helps in the expiration. So that is what happening in the normal inspiration and expiration. So coming to unit of pressures, the ventilatory pressures are commonly measured in centimeters of water. Usually we have units of millimeter of mercury and centimeter of water. All the ventilatory parameters and all pressures regarding the respiratory physiology, we are measuring in centimeters of water. Just understand that the atmospheric pressure at the sea level is 760 millimeter of mercury, which is equivalent to 1034 centimeters of water. By default, we take the pressure as 0. That is, and the surface at the sea level, the pressure that is exerted by the atmosphere on us is 0. That we are, for our convenience, we are taking it as 0. And every pressure that is measured above that will be displayed on the ventilator as centimeters of water. So suppose we see a pressure of PEEP of 5. It's 5 above the atmospheric pressure. So actually, if we want to know the exact pressure, we must add that 1034 centimeters of water to that. So we usually do not do that. We just make this pressure as a baseline pressure of 0, that is the atmospheric pressure. So definition of pressures and gradients. So coming now, we are going to discuss a few terms, that is pressures. Regarding pressures. One is the airway opening pressure. Airway opening pressure, it's also called mouth pressure or the mask pressure. This is the pressure that is applied to the upper airway or the airway opening, the pressure that exists at the opening of the airway of the patient is known as the airway opening pressure. If you are not applying any extra pressure to the patient, it's taken as zero. That is, the atmospheric pressure is what is existing at the opening of the airway of the patient. That is atmospheric pressure. But if you are using a positive pressure ventilation, it will be more than zero. So next pressure is the pressure at the body surface. That is the pressure that is existing around the chest wall. That is around the chest wall. That will also be zero when we are not applying any other pressure, except in cases if suppose the patient is in a hyperbaric chamber, there will be excess pressure outside the chest wall of the patient. That will be positive pressure. And in a negative pressure ventilation, such as in an iron lung, which is just used in past days, will be there will be a negative pressure. So I will show the picture, then you will understand. Next pressure, first pressure was airway opening pressure. The next one was the body surface pressure. Third one is the intrapleural pressure. That is, intrapleural pressure is the pressure that is existing between the parietal and the visceral pleura. We know that the visceral pleura will be adherent to the lungs, and the parietal pleura is adherent to the chest wall cavity. And the pressure that is existing between these two layers, that is inside the pleura, pleural space, is the intrapleural pressure. You know that it's in spontaneous ventilation, in normal physiology, it is negative pressure. That is, at resting, it is about -5 centimeters of water. Just understand that. Next pressure is the alveolar pressure. Alveolar pressure is also called pulmonary intrapulmonary pressure. It is the pressure that is existing inside the alveoli. So we have four pressures we discussed. One is the pressure that is existing at the opening of airway. It is equivalent to the atmospheric pressure. We are not applying any extra pressure. Next is the pressure at the body surface. That is will also be equivalent to the atmospheric pressure. We are not applying any extra pressure. Then next is the intrapleural pressure, which is a negative pressure that is existing between the two layers of the pleura. And next is the alveolar pressure, that is the pressure existing inside the alveoli. So also it is also called intrapulmonary. It is the we also say that it is the pressure that is existing inside the lung. That is the lung pressure. That is also the alveolar pressure. So we understood there are four pressures. So now we are discussing the pressure gradients. So for any flow to happen in ventilation, the flow is we are discussing about the air flow. So the flow of air to happen, there should be a gradient. If the two pressures at the end of two ends are equal, there will not be any flow. When there is a difference in pressure, the flow of the air happens from the higher pressure to a lower pressure. So there are four gradients of pressures that are existing inside the respiratory system. First is a trans airway, second is transthoracic, the transpulmonary or transalveolar, and the transrespiratory. So these terms are actually self-explanatory. We can come to the details. This is the diagram that is showing the pressures. Hope you can see this. First, see this pressure at the opening of the airway. This airway opening. And thus we have an airway pressure of PAW is also airway. Both these are almost same. That we take it as in a spontaneously ventilating, spontaneously breathing patient, it is the atmospheric pressure, that is zero. So then next we have this. This is the airway, and at the end of we have the alveoli. The pressure existing inside the alveoli is not P alveoli, or this is the alveolar pressure or the pulmonary pressure. Then we have the dark blue is the lung, and the light blue we have the pleural cavity. So the pressure existing inside the pleural cavity, all this space is the intrapleural pressure. And the third pressure is what is existing on the body surface. See, this is the body surface. This is the pressure at the body surface. These are the four pressures. Now coming to the gradients. Now see this, the pressure that is existing between airway and up to the alveoli. This will be trans airway pressure. See this across the airway. That is self-explanatory. That is pressure existing across the airway. That is trans airway pressure. So we see that if the trans airway pressure is zero, which means that there will not be any flow. The trans airway pressure is positive. See the airway or the pressure at the upper part minus the pressure at the alveoli. This is positive. We get a flow into the lung, and if it is negative, we get a flow out of the lung. Means a trans airway pressure. Next gradient is a transpulmonary pressure, which is this transpulmonary pressure is the most important pressure gradient among all these four, which will be used to explain various physiologies in various diseases in the coming classes. So this is a transpulmonary pressure is the pressure difference between the alveoli and the pleural pressure. So this is alveolar minus the pleural pressure. So which means that the alveolar, if it is positive, what does it mean? The alveoli will expand. That is, pressure is happening from the alveoli to the this pressure inside minus outside will be positive, means it will expand. If it is negative, what will happen? The alveoli will collapse. So, what we are aiming in ventilation will be keeping a transpulmonary pressure of positive. So this is the transpulmonary pressure. Next is the transthoracic pressure, that is across the thorax, which means including the lung and the chest wall cavity. It will be the difference between the pulmonary, so the alveolar pressure minus the pressure at the body surface. That will be a transthoracic pressure. And there is a transrespiratory pressure, which is which constitutes all these pressure, which will be difference between the pressure airway minus the body surface pressure, which include all the sum of all these pressures. Those are the four gradients. So trans airway pressure we already discussed. So also see that the trans airway pressure, I said that this is the gradient that helps to flow of the air from the airway to the alveoli. Mainly, this pressure helps in overcoming the resistance of the airway, and means that it means that there is a higher resistance, the trans airway pressure will be high. Then transthoracic pressure is same as it is the pressure across the difference between the across the thorax, which include the lung and the chest wall. So it is the pressure required to expand the lung along with the chest wall. So transpulmonary pressure is the pressure difference between the alveolar space and the pleural space. We already said that, and so in all modes of ventilation, increasing the transpulmonary pressure during expiration. So I already said that to fill the alveoli, we have to get a positive transpulmonary pressure. That is the pressure inside the alveoli minus the pressure inside the pleura. That difference should be a positive. So in positive pressure ventilation, already the pressure inside the alveoli will be positive. And in negative pressure ventilation or in a spontaneous ventilation, we actually reduce the pleural pressure so that the gradient remains positive. So see this. In spontaneous respiration, the alveolar pressure is, and the alveolar pressure is 0. When the beginning of at the beginning of inspiration, there will not be any flow into the alveoli. So that is the pressure inside the alveoli is taken as 0. Similar to that, the pressure at the airway opening is also 0. So both pressures are 0. So there is no gradient, and hence there is no flow. What happens is that when during inspiration, the diaphragm moves down and the thoracic cavity expands and the pleural space also expands and the pressure inside the pleural space drops. So at rest it is at -5, taken as -5. At rest it is negative because why? Because we have the recoil of the lungs and the chest wall, which are in opposite direction. The lungs has a tendency to recoil inwards, and the chest wall has a tendency to recoil outwards. So these two forces are opposing each other and pulling at each other. So we have but it is at equilibrium. So we have a negative pressure that is existing inside the pleura at rest. So, when during inspiration, what happens is that this negative pressure becomes more negative. So, example, we take it as at rest it is -5. And during normal spontaneous breathing, the diaphragm moves down and the pressure further drops inside the pleural cavity. Suppose it becomes -10. So that negative pressure will be transmitted to the alveoli, and we get a positive transpulmonary pressure, and the alveoli can expand, or there will be a pressure difference between the airway. We get the normal spontaneous breathing, the pressure at the airway opening is 0. And at the alveoli, and when the pleural pressure drops and the alveolar pressure also becomes negative, there will be flow of air from the airway to the alveoli. That is what happens in the spontaneous respiration. In negative pressure respiration or negative pressure ventilation, we are actually applying a negative pressure towards the chest wall. So, and we are pulling it outwards. So, similarly to that of spontaneous respiration, we get a negative pressure inside the pleura, and there will be a net flow of air from the airway, upper airway to the alveoli. In positive pressure ventilation, or in our mechanical positive pressure ventilation, what happens is that we are applying a positive pressure at the airway opening. So it is no more zero, it will be a positive. Suppose it is +5. And the alveolar pressure is already sitting, it was sitting as 0. And when we are applying a higher pressure at the upper airway, there will be a gradient and the air flows inside. So this is how the flow of air happens due to the various gradients of pressures. So transrespiratory pressure we already discussed. It is the sum of all these pressures. It is mainly to it's sum of all the pressures. This diagram helps in understanding the spontaneous respiration. See what we have. See the graph at the base. We have a 0 line at the baseline, and the dotted line is the intrapulmonary pressure or the alveolar pressure, and the dark blue line is the intrapleural pressure. So here there is beginning of respiration, beginning of inspiration. At rest, it is -5. I already said how this -5 comes because of the elastic recoil of the lungs and the chest wall happens in opposite direction. So it is at -5. And the intrapulmonary or the alveolar pressure is 0 at rest. Because there is no flow, and there is no flow occurring of no flow of air happening. With contraction of the diaphragm and the respiratory muscle, see this pressure in the pleural cavity or the intrapleural pressure drops. So it drops up to -10. And there this negative pressure will be transmitted to the into the alveoli or the intrapulmonary pressure also drops. So it slightly drops into 0. It actually drops to -1 or -2, 0 to -1. Suppose it drops up to -1. So when it drops to -1, we get a gradient across. The airway pressure is 0. So from 0 to -1, there is a gradient. So the air flows inside. So when the air flows inside, actually the pressure will equalize. So again, the pressure inside the alveoli will be equal to that of the atmospheric pressure, and the flow of air stops. So at that point, the inspiration is set to stop. And with the expiration, see that when the diaphragm relaxes, the intrapleural pressure again goes from the -10 to -5. So the diaphragm is relaxing. The intrapleural cavity size, the pleural cavity size is reducing, and the pleural pressure goes back to the at rest. So, and actually it's but the lung is and the alveoli is already filled, and this contraction or the relaxation of the diaphragm compresses the lungs, and there will be an increase in pressure inside the alveoli, or in the pulmonary pressure becomes a positive during expiration, and we know the airway pressure is 0. So that again a gradient is created. So now the gradient is in opposite direction. So there will be expiration happening, and the air is moving out. This is what is happening in spontaneous respiration. See, this is the graph of positive pressure ventilation. So suppose at rest, see the pleural pressure is -5, and we are applying a positive pressure to the upper airway. So when you are applying this positive pressure up to the upper airway, this will be initially transmitted to the intrapulmonary. So the intrapulmonary pressure is becoming 0. See, this pressure is moving up from 0 to positive and up to maybe around 12. So if you are applying around pressure of suppose 15 pressure is applied to the upper airway, the intrapulmonary pressure will move up to maybe up 12. The rest 3 centimeters water will be dropped along the airway. It will be used to overcome the resistance of the airway. And see, this pleural pressure is also becoming positive. Anyway, there will be a gradient between the upper airway and the alveoli, and there will be flow of air inside the lungs. So in exhalation, we said that the exhalation is passive in both in spontaneous and mechanical ventilation also. The expiration is passive. So we simply release the pressure. Here we applied a positive pressure. We simply release the pressure, and the pressure here becomes 0. So the pressure which was in the intraalveolar pressure which was positive drops, and there will be flow of air outwards. So that is exhalation is happening. So these are the pressure changes that is happening during spontaneous and mechanical ventilation. So coming to the definition of pressures in positive pressure ventilation. So mainly these pressures we discussed are mainly the physiological pressures. So what are the terminologies that we use for them inside a positive pressure ventilation? So inside, see, this is a ventilator with the circuits connected, and this is the patient. So this is the proximal part of the ventilatory circuit, and this will be the inside the ventilator. So these pressures can be, so how the ventilator is measuring the airway pressure. So some ventilators measure the pressure at the proximal part of the circuit that is very close to the patient, which will be almost equal to the the airway opening pressure of the patient. So we know that the airway opening pressure is airway pressure is the pressure at the tip of the ET tube or at the tip at the face mask in considering an NIV. So that is the airway opening pressure. So when we are measuring at the proximal point, it will be almost equal to what is the airway opening pressure. But some ventilators or most of the ventilators measure this pressure inside the ventilator system. That is, there will not be any sensor at the proximal point. The sensor will be somewhere inside the lung, inside the ventilator, and this will be estimating the pressure. So they know the compliance and various parameters of this circuit, and they will be estimating the pressure at the airway, and it will be displayed on the ventilator screen. And the ventilator will draw a graph or display a graph with the x-axis showing the time and the y-axis showing the pressures, and we get a real-time pressures what is exerted at the airway of the patient. So this is such a graph. See, this x-axis shows a pressure, x-axis is the time, and the y-axis is the pressures. See, with the inspiration starting, so at the baseline, or the baseline pressure means it is at 0. That's before the beginning of inspiration, there is no pressure is applied on the patient or the upper airway, which means that the baseline pressure is 0. So with the inspiration happening, see, this pressure is increasing and reaching a peak pressure. This is not a PIP, is known as peak inspiratory pressure. That is the maximum pressure that is exerted on the upper airway by the ventilator. Next, we have a plateau pressure, which we'll come and discuss. And then during expiration, what happens is that it simply reduces the pressure, or it no more applies the pressure, and the air flows outwards. So the exhalation is happening, and the pressure drops to the baseline pressure of 0. So coming to baseline pressure, the baseline pressure is the pressure relative to which the airway pressure is measured. In this diagram, the airway pressure, the baseline pressure is 0 or atmospheric, which indicates that no additional pressure is applied at the upper airway during expiration and before the inspiration. So that is during inspiration only we are applying the positive pressure. But if you are applying the a pressure that is more than 0, the baseline pressure is when the baseline pressure is more than 0, which is known as the positive end expiratory pressure, or the P. Or if the spontaneous ventilation, it is known as the CPAP. That is continuous positive airway pressure. So in this diagram, actually this baseline pressure is 0. But if we are applying a positive pressure during expiration also, or before the inspiration, it means that we are applying a positive end expiratory pressure for the patient. So peak inspiratory pressure is the highest pressure recorded at the end of inspiration, and the pressure measured during inspiration are the sum of two pressures. That is, the pressure required for the gas to flow through the resistance of the airway, and the pressure of the gas to fill the airway. So I will come to the details. So see this diagram. Here the baseline pressure is not 0. The baseline pressure is around 9 or 10, which means that we are applying a PEEP. or the positive end expiratory pressure. Even before the beginning of the inspiration itself, we are already applying a pressure to the upper part of to the airway. During inspiration, the pressure is increasing, and we get a positive peak inspiratory pressure. And next pressure will be a plateau pressure. The plateau pressure is measured after a breath has been delivered to the patient and before the exhalation begins. So it means that the plateau pressure is the pressure that is existing inside the alveoli at the end of inspiration. So we know that the alveolar pressure at the beginning of inspiration, that in a spontaneous breathing, the alveolar pressure was 0 at the beginning of before the beginning of inspiration, and it drops to negative during spontaneous breathing during inspiration, that -1 or -2. So in positive pressure ventilation, we already said that it becomes positive. Beginning of inspiration, before the beginning of inspiration, if you are not applying a PEEP, it will be 0. If you are applying a PEEP, it will be equal to that PEEP, that the alveolar, the inside pressure will be equivalent to that PEEP. So at the end of inspiration, what happens is that at the end of inspiration, the pressure in the peak pressure will be displayed by the ventilator. That peak inspiratory pressure is the maximum pressure that is existing on the that is applied to the upper airway. But not all these pressure will be transmitted to the alveoli. That the pressure that is transmitted to the alveoli is known as the plateau pressure, or the pressure that is existing inside the alveoli is the plateau pressure. So to measure this plateau pressure, we have a maneuver known as inspiratory hold or inspiratory pause, which we will be showing inside on during the workshop. So how to measure this? So this is just understand, this is a maneuver to measure the plateau pressure. So the plateau pressure denotes the alveolar pressure at the end of inspiration. So this graph shows the first is the positive pressure ventilation, positive pressure breath. So here there is a PEEP is applied. Then there is a slight decrease in the slight fall in the airway pressure, which is caused by the inspiratory effort of the patient. So when the patient is showing an inspiratory effort, that is the patient itself is contracting the diaphragm, there will be a slight drop in the pressure in the first initially in the pleural cavity, which is transmitted to the alveoli and further to the airway. So that slight fall in the pressure is shown as the small dip in pressure, followed by a ventilator-driven positive pressure burst, which reaches up to a peak inspiratory pressure. So, and this flat portion is known as the inspiratory hold portion. That inspiratory hold pressure region measures the plateau pressure, and during expiration, the pressure is falling down. And this is actually a spontaneous breath, which is a negative pressure and a positive pressure. We have of course CPAP or the PEEP is applied at this point, which we will understand with when we are discussing the modes of ventilation. So now coming to lung characteristics. So now now we have already we have discussed the various pressures that is existing inside the lung, various gradients, and what are the changes that is happening during inspiration and expiration, and what are the terminologies that we use for these pressures during mechanical ventilation. Now we are the final part of the presentation, discussing some lung characteristics. So normally normally two types of forces oppose inflation of the lung, that is elastic forces and frictional forces. Elastic forces arise from the elastic properties of the lung and the chest wall. We already said that there are this lungs has an elastic recoil inwards and the chest wall has a elastic recoil outwards. So the frictional forces are a result of two forces. That is, elastic forces arise from lungs and the chest wall. Frictional forces arises by two means. One is due to the resistance to the gas flow through the airways, and second is the resistance of the tissue or the organs as they become displaced during breathing, which means that mainly the abdominal organs, the abdominal contents. So when we have an obese patient with the excessive abdominal fat deposit, so or we have ascites. So all these causes increased resistance to the expansion of the lung. That is that's almost a fixed resistance. Another frictional force is the resistance to flow of air through the airways. So these two parameters, that is the elastic resistance, elastic force and the frictional force, these are mechanically we describe this by two terminologies. One is compliance and one is resistance. So to summarize, we have elastic force occurring due to the elastic properties of the lung and the chest wall, and we describe this by compliance. The frictional force due to tissue resistance and airway resistance, and we describe this as resistance. So coming to compliance. So compliance of any structure can be described as the relative ease with the structure distance. Or the compliance is of the respiratory system is measured by measuring the change in volume that occurs when the change and occurring when a pressure is applied. The change in volume that is occurring when the pressure is applied to the system, or it's mathematically represented as change in volume by the change in pressure. So so we understand that the compliance of a system is the change in volume that is happening due to the change in pressure that is we are applying. So when a system is more, when the lung is more compliant means there will be a more change in volume with the pressure applied, and this less compliant means the volume change is only very less. So another is elastance is simply the inverse of compliance. Elastance is the tendency of the structure to retain its original form after being stressed. So we can take an example of a balloon. So when we have a balloon which is easy to inflate, means that is it is less elastic. Or it is more compliant. When it is easy to inflate, with the lung is more compliant and less elastic. And when the balloon is very difficult to inflate, it is less compliant and more elastic. Means elastic means it retains its original shape. Compliant means it expands or the volume changes with the same pressure. The volume changes more with the same pressure. So diseases that reduce the compliance of the lung and chest wall increases pressure required to inflate the lung. So we have various diseases that causes a decrease in compliance of the lung or the chest wall. Both these diseases will require higher pressures to inflate the lung. So example will be ARDS or a kyphoscoliosis. ARDS decreases the compliance of the lung, and the kyphoscoliosis decreases the compliance of the chest wall cavity. Both this will require higher pressures to inflate the lung. That means the respiratory system is having lower compliance. Conversely, when you are taking the example of emphysema emphysema, they have a higher compliance. So lung has lost its elasticity and it's more compliant and you require only less pressure to inflate. So how do we measure compliance in the ventilator? So we know that the various pressures that we discussed, we have peak inspiratory pressure, the plateau pressure, and a PEEP or a baseline pressure. So we know that what is the pressure that is applied to inflate the alveoli is that we know that at the end of inspiration, the pressure that is existing in the alveoli will be the plateau pressure. So the pressure that is applied to inflate the alveoli will be the plateau pressure minus the PEEP or the baseline pressure. So see that is the pressure that is applied to inflate the alveoli or the lung. So the change in volume will be the tidal volume. So we can take it as compliance of the system of the lung will be the tidal volume by P plateau minus the PEEP. So that is the formula to calculate the compliance of the lung in the ventilator. Usually the ventilator displays it by automatically it will display the measurements. Then now coming to resistance. Resistance is a measure of the frictional forces that must be overcome during the breathing. So resistance we discussed that the resistance arises due to one is the resistance due to airflow through the conductive airway, that is known as airway resistance, and the second is the resistance due to adjacent tissues and organs such as the abdominal organs. So there are two forms of resistance that is existing. The tissue resistance almost remains constant for a particular patient. So for example, a patient is obese, we have more tissue resistance, but it is almost constant during the entire during the entire period of ventilation. The resistance of airflow. But the resistance of airflow through the conductive airway, it is variable and it depends upon the gas viscosity, the gas density, the length and diameter of the tube through which the air is flowing, and the flow rate of the gas. It's defined by the Poiseuille's law. We need not go into the details. Just understand that these factors, the gas viscosity, density, length, diameter of the tube, and flow rate, all affect the resistance offered by the system. So for a particular patient, this gas viscosity, the gas density, and the length of the tube, and almost the flow rate of the gas will be constant. So main thing that affects the resistance of the conducting airway is the diameter of the tube, which means that the diameter of the airway. So what the diseases that causes variation in the diameter of the tube, like in asthma, when this bronchoconstriction, or when there is secretion inside the tube, it narrows down the tube. All this causes increased resistance. So that is that those are situations that increases the resistance. So calculation, similar to calculation of airway compliance, we can also calculate the airway resistance. So see that airway resistance is the resistance offered to the flow. That is means resistance is given by the equations flow by the flow. Sorry, the pressure difference by the flow. So the pressure difference that we know that the trans airway pressure, we already said that the trans airway pressure is the pressure that is existing on the upper airway till the alveoli. So we know that for a positive pressure breath at the end of inspiration, the pressure inside the alveoli is the peak plateau. And the pressure at the upper airway or the airway opening will be the peak inspiratory pressure. So the trans airway pressure will be the peak inspiratory pressure minus peak plateau by the flow of the gas. That will give the resistance. We usually need not calculate. This all will be displayed in the ventilator. So just taking an example, when the flow is at a 60 liter per minute and the peak inspirator pressure is at 40 and the peak plateau is 25, we have a trans airway pressure of 40 minus 25, which is 50. And we convert this 60 liter per minute to liter per second. That will be 1 liter per second. And we can calculate by 40 minus 25 by 1, which will equal to 15 centimeters water per liter per second will be the resistance of the airway. So we lung characteristic, third characteristic. First one was compliance, second is resistance, and the third is a time constant. So we know that the lung is a heterogeneous unit. That means that no two alveoli are of same properties. So it's almost a heterogeneous unit. And some lung units may have normal compliance and resistance, where others demonstrate pathophysiological changes such as increased resistance or decreased compliance or both. So the compliance and resistance of the lung unit determines how fast or slow it fills and empties. So more the time constant, slower the filling and emptying. So I will come to the details. So the time constant is calculated as the product of compliance and resistance. We have for a particular lung, the compliance, we have a compliance and resistance. And the product of these two will give the time constant for that particular lung. So for a time constant is defined as it is mathematically calculated as the product of compliance and resistance. What does it mean? It means that the time constant is the time in seconds that is required for the lungs to inflate or deflate to the 63% of the volume. So suppose the total inspiratory volume of that particular alveoli or the respiratory unit is around 100 ml. So the time taken for it to inflate up to the 63 ml. So initial 63 ml or 63% of the total volume. That is the one time constant of that lung unit. And that how will we get that value is by the product of the compliance and the resistance of that lung unit. So we can see this diagram. From this diagram, we can understand that this x-axis shows the time constants, various time constants, 0, 1 time constant, 2 time constant, 3 constant, 4 constant, 5 constant. See, and the y-axis shows the volume, 20% of the equilibrium. That is 20%, 40%, up to 100%. And 100% means the full alveoli is filled. So this line represents the inspiration. See, by one time constant, almost 63% of the alveoli. It's not of the of 63% of the total volume is already filled. By two time constant, it becomes 86. By three time constant, it becomes 95. And almost by five time constant, it's said that almost reaches 100%. It's around 99.3, it reaches 100%. Same thing applies with the exhalation. By one time constant, it almost reaches 36.8%, means it already exhaled 63% of the volume. And by five time constant, it exhales 100% of the volume. So example calculation, we just know that compliance of 0.1 and resistance of 1, we get a time constant will be the product of these two values, and we get a value of 0.1 second. So in this patient, 63% of the inhalation or exhalation occurs in the 0.1 second. So what is that? What we need to understand the time constant with regard to ventilation is that for inspiration and expiration, we are for ventilation we are setting at IE ratio or TI and TE, that is inspiratory time and expiratory time. So we have to complete the inspiration and expiration of that particular patient. So we must keep at least 3 time constant. At least 95% of the inspiration and expiration should be completed to achieve adequate oxygenation and ventilation for the patient. So that is the importance of time constant. So we have 3 examples. The first diagram is a normal alveoli. So these two are normal alveoli. They see this when in the second diagram, we see the alveoli is thickened, which means they have a reduced compliance. So time constant means same as the product of compliance and resistance. When the compliance is reduced, the time constant is reduced. So it fills easily and it empties also. It fills fast and it empties also fast. See this diagram. In this diagram, if it was normal, it almost completes by almost. It takes more time to fully fill the alveoli. See this diagram. It takes only lesser time to fill the alveoli. Lesser time to fill means it has a lower time constant. And this third diagram, we have the airway is narrowed. Airway narrowed means there will be higher resistance. Higher resistance means we have a higher time constant. So it takes more time to fill the alveoli, and similarly empty the alveoli also. So this has a smaller time constant. This is higher time constant, and we need to set the I time and E time according to the time constant of that particular lung. So just to summarize, how lung characteristics affect ventilator settings. When we have a low compliance, this will require more pressure to deliver the required tidal volume. We know that the compliance is delta V by delta P. So to get the same tidal volume, we need to apply more pressures. When we have higher resistance, we need to apply more pressure to overcome the airway resistance. When we have lower time constant, the lung unit fills and empties fast. Shorter TA and TE will be possible, and longer time constant, we need to set a longer TA and TE. So thank you. If you have any doubt, you can just ask me.
Please use chat box to put your queries, or one of you, we can take turns at unmuting and asking questions also, but to avoid a crowd, please use chat box.
I think in the chat box there is no queries not there, isn't it? I know.
No, sir, not yet.
Not yet.
Okay.
So anybody want to ask? First of all, congratulate Dr. Midul for a very difficult topic. You covered very simply. I think he covered every aspect of physiology in a simple way. I think this is the basics of our ventilation workshop is concerned. I think you have done a wonderful job. Congratulations to Dr. Midul for excellent presentation. Now, I know others can ask questions. Anybody want to ask any questions? We can clarify. So anybody can answer any questions because we have to be any doubt you have to be can clarify your queries. Srile madam, any comment? Srile madam.
Dr. Mridul has handled a very difficult topic. It was a challenging job, but he has done it wonderfully. All the participants actually should go through this, what he has taught once again, or even multiple times, so that you can be thorough. Then only it will be thorough for you. So he has explained everything very clearly, but you have to go through this before next day's class. Then only it will be useful for you and it will make a long lasting effect. That's what I feel. Congratulations, Dr. Mridul.
Thank you, sir. Thank you.
Thank you, madam. Everyone, please use this opportunity to ask all your doubts. It doesn't have to be very complicated. PGs, please ask any doubt that you might have from anything that Dr. Mridul explained to us today.
I know you can. I think I know you can conclude
Yes, sir.
talk by propose photo. Thanks for the program.
So,
Juberi sir,
thank you.
Juberi.
Juberia, in between, sir, I'm not sure. Juberia, are you there?
Or you
So I
you
think her
conclude.
network connection
Okay.
Yeah, okay.
You-
So so today on our opening day of our pre-workshop series, we had an excellent class by Dr. Mridul, and so basics are very important when we go ahead with ventilation. So I think today we have a good firm basics. Tomorrow we have second session by Bindusha madam on modes of ventilation. I would like to thank Dr. Mridul for taking the time to explain each of the parameters in a very simple manner, and all the diagrams were also very helpful for us to get a visual picture of how things work with regard to ventilation. Please, if you have doubts, please keep it in mind. We can even answer those during our workshop on Sunday. So hope to see all of you back here 50 tomorrow evening for Bindusha ma'am's class. And I thank Dr. Mridul, I thank Joe sir, Shilda madam, and all others also. Thank you for active participation. And good night. Joe sir, anything else?
Anu, one doubt. How we
Yeah.
can we access the? This
Yes,
was
ma'am.
recorded. No, how can we access this? Because we have to go through this again for that to be thorough. How can you access it? The the talk has been recorded. No?
Madam, I
So,
think
I think
Yeah.
that will can be shared to the WhatsApp group.
the link, the video, the download, we can share the video, madam. We will be able to share it. I think Nibin, while just confirm with Nibin by when is there any time, we will share it in the same group itself. So those who could not attend today can go through the video before tomorrow's class.
okay, even we ourselves have to go through this
Yes,
again.
yes, madam. Definitely. Yes, true, madam.
Okay.
So
Thank you,
shall
Dr.
we?
Mridul. Thank you, brother.
Thank you, sir. Thank you.
So we
I think we can conclude.
Okay, thank you, Mridul, once again from our part.
Thank you, ma'am.
So we'll conclude today's session. Thank you, everyone. Thank you, Dr. Mridul, once again.
Thank you.
Everybody can leave.